Hi, everyone, and welcome to our HIV 2020 session focused on children living with HIV. Thank you so much for joining us. I know it's very early for some of you and very late for others. My name is Saima Jiwan, and I am a program manager at the Global Network of People Living with HIV, GNP+. Our aim at GNP+ is to improve the quality of lives of people living with HIV. This webinar is in collaboration with AIDS Funds, Coalition of Children Affected by HIV, Health Gap, International Community of Women Living with HIV, ICW, ITPC, PATA, and Y Plus Global. We're very excited about this session. We have 1,100 people who have registered and hopefully more that will be joining us on social media. We hope by the end of the session, we have a group of strong community activists pushing for the rights of children. So before we get started, we have a few announcements to make. All HIV 2020 online sessions are available in English, French, Portuguese, Russian, and Spanish. So to access the language channel, please follow the instructions on the slide. Please choose the audio channel for the language of your choice by selecting Interpretation and then the language. You can mute original video to only hear the interpreter. So just going to go through some participation guidelines. The HIV 2020 online sessions offer a safe and neutral space for sharing of knowledge, experience, skills, and opinions in a mutually respectful manner. HIV 2020 online operates a zero tolerance policy for any kind of bullying, harassment, abusive use of language, aggressive expression of opinions, or any such undesirable behaviors. This includes any activity during the Zoom session or on HIV 2020 online social media platforms, Facebook, Instagram, Twitter, YouTube, that may cause distress to panelists, speakers, translators, and/or participants. Session participants who engage in such actions will immediately be removed from the session with no prior notice. Just to inform you all that this session is being recorded and we will upload the it will be uploaded in the HIV 2020 online languages on YouTube and other social media channels. The session is also being live streamed on Facebook and on the HIV 2020 online Facebook page. Please be mindful of revealing your personal particulars, name, age, country, if you're not comfortable to do so during the session when you interact with others. At the bottom of your screen, you'll see a Q&A icon. Please use that to ask any questions you have about the session, and we will have someone respond to them during the session. And before we get started, I'd like to say a huge thank you to our moderators for the session, Maureen Marenga from Lean On Me Foundation in Kenya, and Florence Anam from MSF in South Africa. I'm going to hand it over to you, Maureen.
Thank you very much, Saima. Welcome, everyone. It's good to have you with us today as we discuss this topic that is very much close to our hearts about children and the HIV response. To start us off, we have what we call the Kigali Declaration, which was born out of the protest that we had in the last year's ICASA in Kigali. So during this declaration, we had different asks from communities. But before I go to the asks, I'll talk about the facts of where we are with childhood HIV. So the facts are that 1.8 million children globally aged between 0 to 14 years are living with HIV. and the needs of HIV positive, pregnant, and breastfeeding women for comprehensive community-led support for their own health and health of their pregnancy is precisely the type of essential service that forms health systems, that formal health systems often ignore. So we know we cannot have a healthy baby born out of a distressed mother, and the needs of women are actually really, really, really important. And then we are in the era of what we call the universal health coverage. And the promise to children with HIV is not very concrete. And most of them are dying without access to point of care, early infant diagnosis. And then most programs are prioritizing incidence, and this ignores the urgent treatment needs for HIV positive children. As in most countries, you will hear them say that the numbers are too low. And we always also say that no life is less important, all lives matter. So vertical transmission rates are stalled at 12.7% globally. Vertical transmission is what some of us call mother-to-child transmission, and some of us feel that is very victimizing. So we prefer the language vertical transmission. So only 54% of children 0 to 14 years have access to treatment to halt rapid disease. So as we talk of 90, and we talk of the second 90, where all that are diagnosed are put on treatment, most countries are doing really well. But for children, it is still very, very low. Only 52% of children born exposed to HIV have access to early infant diagnosis. I always like to mention that for an adult to know their status, it takes only 20 minutes. But for a child to know their status, sometimes it takes months and years, which is really unfair if we believe in early treatment having better outcomes. And then for those who are tested, 19% receive results in 30 days. This is very dismal. It's really, really bad. So women living with HIV are still at risk of poor clinical outcomes and transmission of HIV during pregnancies, deliveries. Systems are not providing remedies to what they experience, such as stigma, discrimination, attitudes, and other injustices. So we have heard about some of the treatment women receive when they go to hospital, and especially if they're young women, the stigma is usually double. And my friend Martha from Zimbabwe, Martha Tolana, says that they actually they don't default. Sometimes they're called defaulters, or they don't get lost to follow up, but they're bullied out of treatment. Also that women are not getting adequate support during breastfeeding, because the community-led support they need, sometimes it's not adequate, or the healthcare providers become harsh. So like we said, we need support as women, both at the facility and also back at the community. And we find that there's very, very little financial and other support for community-led initiatives for women who are living with HIV. And then, so based on those facts, we had demands when the declaration was done at Kigali. And some of the demands we made were that pregnant and breastfeeding women at risk of HIV infection require access to PrEP and other high impact prevention measures, as well as HIV testing during pregnancy. We know most programs, they test during the first trimester or the first time a woman goes to the facility, and that's it. So during pregnancy, nothing happens, no prevention interventions, no testing is done. And then we also know that there are women who seroconvert during pregnancy and also during breastfeeding. So this is something we think that needs to be done so that we may we are sure that the mother is healthy and they can have healthy babies. So all children born exposed to HIV must have point of care early infant diagnosis. And this is a challenge to many countries. When we talked about male circumcision being an effective prevention tools, resources were given to our countries. Men were circumcised until there are no more men to circumcise. But when it comes to point of care, early infant diagnosis, to accelerate initiation to treatment for those children that are HIV infected, then there's a lot of laxity. So these are some of the demands that this is accelerated and countries actually scale up point of care early infant diagnosis. And then also the issues around the violence, physical and sexual, that women face during pregnancy. We require health systems to respond to these needs and accelerate access to justice for women. Another demand is that children with HIV need powerful treatment regimens that can deliver viral suppression. Like I told you previously, we are failing in all the fast track targets of UNAIDS, the 90-90-90. We are failing to diagnose children on time, the first 90. We are failing to start them on treatment, and those that are started, the numbers are very, very few. And they're not achieving viral suppression because of the kind of treatment some of them are in. We have children who are on heat-sensitive medication, and they live in houses where they don't have refrigerators and the temperatures are too high. That compromises the quality of treatment, and despite the fact that these children are on treatment, they are not achieving viral suppression. So another demand is that if children need effective screening, diagnosis, and prevention and treatment for the main threats they face, such as pediatric tuberculosis. And we know pediatric TB is another area that is really wanting. In some countries, there's hardly treatment for MDR, pediatric TB, and therefore children who get MDR just die. So children living with HIV and their caregivers need HIV programs that guarantee all HIV positive children are provided community-led service delivery interventions. And if you went to many country programs and asked them what programs they have for children, they point at PMTCT. And that just takes a bit of children who are in the health system. It leaves out the children born in their homes or in the traditional birth attendants. And then also it leaves out children who are beyond 18 months. And then we also asked that national program must develop public 95-95-95 targets for 2020 at the national, subnational, and local levels, together with public tracking of progress and setback. And this must be desegregated because we know most countries are putting 0 to 15 years, but we know the challenges that 0 to 5-year-olds face are somehow different from 10 or 5 to 15. And also some of that data, we lose pediatric data if it is all summed up as one. We also talked about the funders like PEPFAR, that PEPFAR must support a scale up of point of care early infant diagnosis and powerful, durable pediatric treatment as a condition for COP 2020 implementation. And we know advocates have been working at country level to try and achieve this. We also know some of the hesitance in terms of setting up these, availing these commodities in the country COP 2020. We've also asked that the Global Fund to fight AIDS, TB, and malaria must support countries to use the 2020 to 2022 implementation cycle grants to scale up point of care early infant diagnosis and also optimal treatment for children and pediatrics. And again, this is the time when most countries are submitting their proposals to the Global Fund. The grants have not been finalized, so there's still a window of opportunity for advocacy and inclusion. And then we also know that pharmaceutical companies must avail affordable drugs for children. And also we demand for a robust research and development plan for improved child-friendly treatment formulations. If you look at adult formulations for HIV, we have really accelerated. I think we have had more than 20 regimens that have been launched since HIV first was discovered. But for children, the process is very slow, and the excuse again around numbers is not acceptable if we have to save lives. And then to governments, we demand that they must deliver rapid increases in HIV funding to address pediatric HIV emergency, so that pediatric programs no longer hide behind the excuse of insufficient funding. So this call is to domestic resources for pediatric HIV. And if we look at how much countries put towards pediatric HIV compared to other pediatric health issues, then we know why this demand is critically important. So that's basically, those are basically the facts around childhood HIV, and also the demands that were made from the Kigali Declaration from the civil society and community members that engaged in that process. So besides that, it's always good to hear what's happening in our countries. What does the picture look like? What are the issues affecting children, even beyond the Kigali Declaration and beyond other targets that internationally have been made around childhood HIV. So to start us off, we are going to have Anna Sango from Y+ Global, who has joined us, and she's going to give us a small presentation. Anna, back to you.
Okay. Hello, everyone. Thank you so much, Maureen. Okay. Hi, everyone. Thank you so much, Maureen, for the wonderful presentation around the work that needs to be done for point of care. Yes. So around the work that needs to be done for point of care. So first, let me just reintroduce myself. My name is Anna Sango, and I am currently working with a network for young people living with HIV based in Zimbabwe, known as ZY+, Zimbabwe Young Positives. And I'm also part of the Y+ network, which is the global network of young people who are living with HIV. And the issue of point of care and early infant diagnosis is very pertinent and important to me as a young woman, as well as a young mother. And looking at issues of treatment and ensuring that children and infants are put on care, are put on treatment, and they are identified early is really, really important. I actually have 2 babies that I had through the PMTCT program in Zimbabwe, which I also want to applaud for the work that they've been doing. And I managed that process and getting my babies tested and the time frames that it took and all the anxiety around that. And through that process, I also feel that what other young women my age were feeling as well currently, if the situation is not addressed, or the situation is not, if we're not doing any initiatives or strides to actually address the issue of making sure that our infants are tested and they are put on treatment early. So on our first slide, as you can see, 56% is the number of exposed infants who are tested before the age of 2 months. So looking at this is very, there is some work being done, yes, but at the same time, it is very also disappointing because we're missing out on a lot of children, meaning that there's a lot of mothers who are positive out there and whose children have been exposed, but we're not really meeting the targets, even if the work is being done, but we're not necessarily being able to protect and save our babies. And then you find that almost 71% of those children are actually on treatment. So also, it looks like a big number as well within our context, but at the same time, it leaves a lot to say. We still need to be doing more. There still are so many children and infants that are going unidentified and that are not being put on care as soon as possible. And this is not what we want for our babies. We want our babies to be safe, we want our babies to get mental health when it comes to knowing that either their children have been tested and they're going to be getting the care that they need. Next slide, Saima. So what is currently happening right now is that point of care machines are available in Zimbabwe, but you'd find that there is limited coverage in terms of their availability. Or rather, if they are centralized at a point whereby people cannot easily upload that in easier. For mothers and caregivers of those children and these infants to be able to access such a service. But if it's not readily available, or if it's inaccessible in terms of affordability, or if it's inaccessible in terms of distance, it then becomes a big challenge for young mothers and caregivers who are caring for infants or babies who may have been exposed. There's more work that needs to be done. Care machines within facilities, and they are easily accessible to parents and guardians and mothers of our babies and infants. And then you'll find that even where the point of care machines are available, there is limited information. And usually this is derived from high levels of fear and stigma. There's a lot of stigma when it comes to having your babies tested. First, it's the internal stigma that the mother faces, and also the external stigma that is there. Because for most mothers, they envision that once someone knows their baby status, they can automatically confirm their status as a parent. So in order to guard their own interest and their own status from being known, they'll actually not have their babies or infants tested because they are afraid. And this is very detrimental and such a setback when it comes to us wanting to ensure that the babies that are exposed get the treatment that they need on time. There are so many examples of young women who have been abused, young women who have been shunned out of families, out of community, just because they had gone the initiative of actually getting their baby tested because they had been exposed to the virus. So this is very, very, very challenging. And I think as communities, we really need to work towards addressing the issue of stigma. We might feel that it is not a big issue, but when it comes to young mothers, especially when it comes to young mothers, it's really a challenge that we really need to tirelessly work on and address, and ensure that we're providing the adequate information, we're providing the adequate awareness, and also providing the adequate tools that they can be able to use so that they can be proactive and have agency in terms of seeking health facilities and also health services for their babies. And then you'd find that also we have different funding models that are there that are also working tirelessly to ensure that the infrastructure is in place in terms of making sure that the service is available. What I'm trying to say here is you might find that in Zimbabwe we have a challenge of power cuts. So you find that most of the time, the point of care machines need power to be used. So when there is no establishment of either solar power or any other initiative that can support the working of these machines, it then becomes a challenge, and then access already becomes a challenge for those that want to access the services. So it's important that we have the right infrastructure in place. If it's then looking for external sources of power to ensure that they're there, if it's also looking at ensuring that the cartridges are there, and that also making sure that all the IT equipment that may be needed to be utilized is also in place, will go a long way in terms of us achieving what we want to achieve. So there is remarkable progress that has been made in terms of also adopting the guidelines on point of care, but then there is need to put pen to power. There is need to ensure that we are living the talk, what we have agreed on, and the guidelines that we have adopted as a country. There's so much need to ensure that that is materializing on the ground, and that all healthcare providers are trained and they know how to use point of care machines. They are fully aware, and they are also strengthening their support system in terms of follow-up as well for these infants. And to make sure that also as activists, we really need to push our governments to ensure that they abide by these guidelines and that they fully invest and commit to these guidelines so that we can be able to achieve the results that we want to achieve. Next slide. So what we need What we need is to ensure that there are more point of care machines within facilities, and that there's also information around access to early infant diagnosis. We know that even in as much as a lot of parents and a lot of caregivers are fearing to take their babies to the hospital, we need to work tirelessly as networks and as groups and as activists around this issue, because it's an issue that is pertinent to our heart. It's an issue that is important. We need to make sure that we work towards ensuring that there is the adequate information within communities such that they understand the need, why our young people need to be able to get the services. And that's why we have a wonderful, wonderful tool that GMP Plus within other partners have managed to come up with, a tool that specifically looks at addressing the gaps in terms of making sure that services are available, a tool that we can use as community-based organizations, as networks of people living with HIV, to be able to demand, to be able to promote demand creation among parents as well, and to ensure that the strategic framework around point of care is being rolled out efficiently and sufficiently. There's so many tools that accompany this wonderful, wonderful no time to wait tool. We have posters, beautiful posters that can be really used within our facilities, that can be really used within our support groups, that can be really used within other stakeholders and other partners to ensure that people fully understand which gaps we need to address, and the importance of ensuring that we have the right services within the right time for the right target group. So that's very, very important, and we really look forward to having this framework being adopted by certain groups of networks of people living with HIV, because people living with HIV and their groups and networks are the ones who are working in the communities. They are the ones who are continuously with mothers that can be facing within the community. So it's important to have them spearhead and champion this initiative and intervention to ensure that everyone fully understands, so that we don't leave anyone behind. And then we also need to work on ensuring that there's investment in work of these networks and CBOs, so that they can be able to support the parents or the caregivers and families as a whole as well, to be able to go through the process in terms of managing the results if an infant has tested positive, and also to be able to refer if there are any other issues that they may need support in as well. And also to be able to also make sure that there's adequate information for the mother as well, to be able to continue to care for their child in the event that also maybe the child has turned negative. So it's important to ensure that these networks are fully resourced, fully supported, be it technical support, be it human resources, be it financial support. That's very, very important to ensure that this happens. And then we also need to increase our community engagement, especially for young mothers and also for single fathers. Because what I've been noticing lately, especially within the situation around COVID, a lot of mothers died and then a lot of fathers who have to be left to care for these young babies. And when we're making our interventions, when a mother is going to ANC, most of the time we are targeting the mother because she's the one who's coming. But in the event that she dies at childbirth, the care of the child is left in the hands of the single father, who's also, and then also having the burden not be a pertinent issue for them to then follow up on issues of making sure that the child is tested and that they ensure that the child who was exposed to HIV is probably safe, or they may need treatment. So it's important also to consider them as a significant group as well that is there. And then we also need to ensure that marginalized communities are being able to be reached, especially when it comes to rural setups, because you find that most of the time point of care machine will be centralized in a location that they probably have to catch 2 buses to get there, or the distance they have to walk to get that facility, they might not be able to afford, they might not be able to access it within time. So at the end of the day, we need to ensure that marginalized communities needs, they are also addressed, to ensure that point of care machines are placed where they are strategically placed, where people can access them. And what we want to do as activists, as mothers, as parents, as caregivers, is to continue to bring attention to this issue of ensuring that our infants are tested early and they are put on treatment early where they need to. We do not want to lose our babies. We do not want to lose our children. We want them to grow and lead amazing lives. But it all starts from us as a support system. It all starts from the structures that are there that we put in place to ensure that this happens. So we will continue to lobby and ensure that diagnosis for the early infants and also for children, finding the missing children, is going to be happening. Thank you.
Thank you very much, Anna, and thank you very much for those insightful recommendations. Next, we have Jacqueline Okinyi from WOFAC, Women Fighting AIDS in Kenya.
Hi, good afternoon, everyone, and thank you so much, Maureen. I am Jacqueline Okinyi from Women Fighting AIDS in Kenya, and I'll be talking about the needs and rights of women during pregnancy and breastfeeding, and of course, focusing on what is happening in Kenya. We all know that globally we have over 36 million people living with HIV, and out of this number, we have around 2 million who are children. A lot has been done in terms of addressing the needs of children living with HIV and ensuring that we have a lot to do to ensure that we reach our set target, especially for 2018 and 2020. Women living with HIV have the right to breastfeed their children. And despite the progress and the gains that we have made in terms of vertical transmission or prevention of mother-to-child transmission, we still believe there are a lot of myths in the community that really affect the way women living with HIV handle their children in terms of breastfeeding. We have serious breastfeeding benefits, both for mother and children living with HIV. And we believe that every woman or living with HIV has the right to breastfeed their children for both the need of the mother and that of the child. There are various benefits. Some of them are directly of benefit to the children, including nutritional support. We know that all children are supposed to be breastfed up to around the age of 18 months. In terms of the motherly weight loss after pregnancy, breastfeeding supports this. We also encourage our women to breastfeed their children to lower the risk of both breast and ovarian cancers. So we still need a lot of information in the community and a lot of education to just demystify the myths that are there around HIV and breastfeeding. Next. There is increased acquisition of HIV in the course of pregnancy. And as a routine, what happens is most of the mothers go to the facility and are tested for HIV during their first antenatal care visit. And then after that, no more tests are conducted. Between the time of the first antenatal care visit and the time that a woman goes to deliver, there could be HIV infection in between. So what this means is that all pregnant mothers have the right to access HIV treatment support, which includes testing right from the time they go for their first antenatal care up to the time that they deliver. We need breastfeeding and treatment support from the families, from the healthcare providers, and the general society, just to ensure that women are adequately supported. And at a quick turnaround time for results, care, early infant diagnosis, still we still children to a central laboratory at the
We seem to be losing Jackie. So I will continue with her presentation as we wait for her to come back. So on the screen, there is rights and needs of pregnant and lactating women. So some of the rights and needs are adequate services to support so that we help women protect themselves from acquiring HIV before and during pregnancy and throughout breastfeeding period. So like I mentioned before that women are tested just when they go to the facility. And then during pregnancy, sometimes even those who feel that they are at risk are not provided for any HIV prevention. But we also know that to get healthy children, we must care for the mothers. And then HIV testing should be provided as part of care women receive before, during, and after pregnancy. So HIV testing should be a continuous service that women access during all that time. Then breastfeeding and HIV treatment support from families, community, health workers, and society for women living with HIV is very, very important. So we need women supported with treatment literacy, adherence counseling, supported to care for their nutrition and that of their child throughout the breastfeeding and treatment cascade. And then finally, I'll talk about access to early infant diagnosis and quick turnaround time, which we have talked about since we started this call. Jackie is back, so she can continue from the next slide.
So thank you very much, Maureen, and sorry for that technical hitch. On the current challenges for pregnant and breastfeeding mothers in Kenya, we have number one is nevirapine stockout, which has been there for some time. This is a big challenge because most of women now give birth and they cannot breastfeed their children because of fear of HIV infection. We also have a lack of access to point of care, early infant diagnosis, which we have talked about. We have COVID-19 as a big challenge affecting pregnant breastfeeding mothers as well as the children. There's economic turndown in Kenya and lack of food as a result of COVID-19, since most people have lost their jobs and they cannot therefore afford to feed their families. What this means is that we'll have a gap in terms of ART adherence, because it is difficult to take ARVs without food. We also have many of the facilities in Kenya which provide HIV care have been turned into COVID-19 isolation and quarantine centers. So what has happened is that most of the people living with HIV have been transferred to other facilities for access. This transition was not done properly, and we've had a lot of challenges and complaints in the community where people, especially women living with HIV, do not know where else to go for their HIV refills. Most of them were asked to wait for phone calls to be directed on which facilities or clinics to go to, and this has not happened. And then we also have, due to COVID-19, a lot of sexual and gender-based violence, which has resulted to so many teenagers getting pregnant. And this is really challenging in terms of service provision. Maureen mentioned earlier the challenge we have with young women accessing care in the facility. There's a lot of judgments going on. They are stigmatized at the facility, and this therefore becomes a very big challenge. Next. As Women Fighting AIDS in Kenya, we have quite a number of interventions that target women and their children, especially women living with HIV. And there are two of our responses that we would really like to highlight. And one of them is called Inuka Initiative, which is improved access to pediatric HIV care through a community intervention model. Inuka is just a Swahili word meaning arise. So WOFAC has been supported by AIDS funds since 2019 to conduct case identification for children living with HIV in Homa Bay County. Homa Bay County is one of the counties in Kenya which has high HIV prevalence. So what we do under Inuka Initiative is we work very closely with the Ministry of Health. We work closely with the National AIDS Control Council and NASCOP, just to look for the children in the community with a belief that they are children who are not yet reached. In the communities, especially here in Kenya, we still have women who conceive. They do not attend their antenatal clinics. They end up giving birth at home with the support of traditional birth attendants. So what this means is that these women give birth without knowing their own status, and thereafter not knowing the status of their children. So the children stay at home and are not tested. So this is what Inuka does, just looking for these children, of course, using a community approach through the community health volunteers to just bring them to care. And we also target their caregivers with various interventions, including economic empowerment to just ensure retention to care and achievement of viral suppression for these children. As a result of our work in the community through Inuka Initiative, we have realized that there are a lot of gaps that still exists in the community. And what this means is that a lot should be done by implementing partners, civil society organization, like-minded partners, as well as all our governments from national to county governments to just support the identification of these children. Since 2019, mid-2019 actually, we have been able to identify 572 children who are not yet in care. We have supported, linked them to the facilities. We have ensured their retention to care and viral suppression. We have also identified 624 women, pregnant women, linked them to care for prevention of mother-to-child transmission, and just ensuring that we support them through their journey of taking antiretroviral therapy. In the midst of our work, we have had one death of a child, which was related to the measures that we have, the containment measures for COVID-19, which I mentioned earlier as a challenge that really creates a barrier to HIV service uptake. In this particular case, a child felt sick and was being taken to the hospital. They met policemen at a barrier where they check the temperatures, as they usually do. And when they realized that the temperatures were a bit high for this child, they could not allow them close to the facility. So they spent around 1 hour at the roadblock, and the child ended up dying on her way to the hospital. So some of our recommendations is that we really need to invest in community-based organizations to scale up community-based interventions like Inuka. So we call on our government, we call on all the like-minded partners to come together and support community initiatives that are geared towards ensuring safety and good health for children living with HIV. And also access to point of care, early infant diagnosis, just to ensure that we have diagnostic results in time. We need to ensure that each facility has the technologies that are required so that children are tested in time and that they receive their results in time. We've had a lot of anxiety running where the caregivers wait for the test samples to be taken to the central laboratories for HIV testing. They have to wait indefinitely. Sometimes it takes more than 1 month for a caregiver to get the results. And during this time, there's a lot of anxiety rising. In some of the facilities, the caregivers are asked to call. No, sorry, they're asked not to call, and that they will be called in case the results are positive. And if they don't see a call, then they should instantly assume that the results are negative. This leads to a lot of anxiety with the caregivers, and also it interferes with the real-time provision of services, HIV services to our children. The recommendations also, we need to have community health service providers also supported in terms of information and education so that they have the right skills that are required to attend to children living with HIV. Another intervention that we would like to highlight is the sexual and reproductive health rights for women living with HIV. This work started in 2017, of course, supported by UNAIDS, where we were engaged to work on the SRHR checklist for WHO. The dissemination and piloting was done in Nairobi, and this work has been cascaded in 6 counties, where we just engage women living with HIV to get their opinion on what kind of services they would want to access both at the community and at facility in terms of sexual and reproductive health. We have trained 60 women living with HIV who are now acting as SRHR activists in their counties, and we really wish to cascade this to the other remaining counties. As a result of this, we have established strong support group, psychosocial support group for women living with HIV. Since in the course of our work in the community, we realized that psychosocial support group is a big gap, especially for women living with HIV who have a lot of burden, be it in the family or in the community. The burden of taking care of the family, the burden of taking care of their children and having to nurse their pregnancies, of course, also adhering to ARV medication. So we feel women should have a platform where they can come together to discuss the challenges they go through as women living with HIV, and also just make sure that they support one another in their journey with HIV. So the support groups are already established and are running, though we still do not have enough support for this. Our recommendation on this is that we would like to request the partners to support such initiatives that directly involve or directly work with women living with HIV to ensure their support. Such projects should be cascaded so that every woman living with HIV is reached out to. We have one success that we can highlight on this, and that is the inclusion of sexual and reproductive health rights as a key focus in the Kenya AIDS Strategic Framework 2, which has just been developed in Kenya. So this is a success, and this is something that should be emulated both in country and even globally. The healthcare workers still need a lot of support in terms of HIV service delivery at the facility. We realize there's a lot of stigma going on at the facility level. And just as Maureen mentioned before, some of our children drop out of care, not because they are defaulters or not because they want, but because they have literally been thrown out of care. The environment that they have at the facility is not conducive for them to stay around. So they opt to leave. And because of these challenges, we have lost so many young people out of care. Same to young women, same to our older women who also expect to receive services at the facility. Most of the time, the facilities do not offer the services they want because of the judgment. You go there, you are HIV positive and you need to be on treatment, and then they ask you how many children you have. And instead of just talking to you and guiding and counseling you well so that you're able to take your medication, you face a lot of animosity and a lot of judgment at the facility. This has interfered with service uptake. And a lot needs to be done to create demand for services at the facility. It is a two-way. As we create demand at the community, we must also be able to ensure that the facilities are ready to receive women and children living with HIV to ensure quality service provision. Thank you.
Thank you very much, Jackie, for the wonderful presentation. Participants, please keep sending your questions through the question and answer platform. Now, our next presenter is Charlene Donald from AIDS Foundation, South Africa. Welcome, Charlene.
Thank you. Hello, everyone. My name is Charlene Donald, and I work for the AIDS Foundation of South Africa, working at a community level, focusing on addressing the issues that cannot be dealt with in clinics, but continue to hinder progress towards an AIDS-free generation. Next slide, please. South Africa is currently at 77, 60, and 66 respectively against the 90-90-90 targets for children under the age of 15. These figures are infuriating considering the progress made in adult diagnosis and care. We cannot continue to ignore the reality that HIV does affect children and adolescents. In South Africa, systems are in place for early infant diagnosis, but we failed to implement a regular testing regime after birth, relying on caregivers' willingness to test, their openness to accepting the realities that children are vulnerable to HIV infection. Stigma erodes this willingness. To avoid the fear and stigma of having an HIV-positive child, caregivers simply avoid testing. Children face high levels of sexual violence, and because we don't talk about sex in our culture, we pretend that children aren't at risk of seroconversion. Adolescent mothers are shamed by staff in clinics, and so they don't access testing services, and their children are often lost to follow up. These issues are deep-seated and result in children not being tested. Those that are diagnosed continue to face stigma and judgment. That's only if they are disclosed to, making adherence difficult, and ART medication becomes a family secret. The lack of psychosocial support makes it hard to reach the third 90. Pediatric medication, as we know, is largely unpalatable, and economic vulnerabilities and access to health facilities which have always been tenuous, have been exacerbated by COVID-19 and the current situation we're in. Next slide, please. South Africa is recognizing the need for community clinic collaboration. Across the country, organizations are reaching out to clinics, and clinics themselves are moving into communities through outreach teams and the use of mobile clinics. A child is then found in the community through testing strategies, is referred to the clinic, which only forms part of the whole system of support, and is then referred back to the community through various linkages and other civil society organizations that are doing work, is then given multiple support at a community level. Services that address issues relating to mental health, nutrition, education, and economic strengthening support. Because HIV is not just a health problem living in a facility, but these issues are structural and they are at a societal level within the community. The community clinic collaboration model works, but it needs resources, unfettered by gag orders and conservative views that limit implementation. Clinics need youth-friendly services and to acknowledge community partners to fight HIV and enable us to reach 90-90-90. Next slide, please. As international activists for children and adolescents, we need to learn from each other and do better. Community case finding that works involves acknowledging the reality of early sexual debut, that shifting consciousness and agency is critical, and that bringing testing services into the community is effective. Case finding strategies that have worked in South Africa and need scaling up have been indexing older sexual male partners to find the younger adolescents, as well as indexing siblings and children with different biological parents. Through this method, we have been able to reach yields of up to 53% positivity rate, but the approach needs to be highly sensitive, and trust and confidentiality are key. By distributing MTV sugar material to adolescents, they themselves have been able to recognize their risk and request an HIV test. This method has reached yields of up to 31% positivity, which emphasizes the importance of agency. They test because they want to, because they recognize that the things that they see in the MTV sugar material are relevant to them, not because they're told to test or are at risk. The use of mobile clinics in underserviced communities increase anonymity, making people more willing to bring their child to test because there isn't the stigma or the same person seeing them all the time that results in the fear that we've mentioned and we've spoken about. All these strategies are resource intensive and require acknowledging the importance of children and adolescents. Next slide, please. We cannot deny the impact COVID-19 has had. To continue to improve the second and third 90 during this pandemic, South Africa is focused on art delivery, multi-month dispensing, and increased provision of virtual support through bulk reminder messaging, regular phone calls, and the use of WhatsApp for support groups. This too has come with its own limitations and is not a solution to an ever-increasing child-headed households as caregivers pass away from COVID. This doesn't solve the increasing hunger as households lose income due to COVID job losses. We need to improve and expand on community integrated responses, and to do so we need resources. We have to continue to advocate for these children and civil society organizations and community-led responses. As long as pediatric and adolescent HIV is not a priority, children will continue to die. And as activists, we need to reaffirm our commitment to fight for the next generation. Thank you.
Thank you, Charlene, and the really, really strong point you have ended in around the role of advocates to ensure that our children do not continue dying for conditions that can be saved. So the last speaker for this session is Buki Ainde from AfroCab. Buki, you're welcome.
Thank you. Hello. Good afternoon, everyone.
Buki, we can hear you.
Okay, good afternoon, everyone. My name is Bukola Ainde. I'm a member of the AfroCab in Nigeria. and I'm going to be talking about community-led service delivery for HIV, another main health threat to children. Next slide, please. Yeah, as we have heard and as stated in the Kigali Declaration, we need to wake up because a lot of HIV positive children are dying and suffering due to absence of needed HIV care. Next slide. Next slide, please. Okay, community-led service delivery. I just want to say that if you look at some of the points highlighted in this slide, it's talking about some of the demands from the Kigali Declaration and also some of the expected outcomes from, from intervention of with HIV positive children care. So in addressing each slide or each point, I'm going to be talking about where we have challenges in Nigeria attaining some of these mentioned points. The first one, the reduction in vertical transmission. This has been
Looks like we lost Buki. So Buki was making a presentation on the importance of community-led service delivery for children and pediatrics. And she was talking about the benefits. Is she back? About the benefits, such as it supports the reduction in vertical transmission. It supports also accessing cheap and feasible rapid diagnosis, because we have all been talking about point of care early infant diagnosis. And this is the type of diagnosis that can be done by a nurse or not necessarily by a lab attendant, and therefore it's easy to cover more people even in the hard to reach areas. Community-led delivery also for increasing HIV testing services coverage for adolescents. Communities are well known for providing community-friendly treatment literacy and education. And with that, she's back, so she can proceed. Buki?
all right. Thank you very much. I'm back. Can you hear me?
You're
Hello?
not very clear, Buki. Yes, yes. So
Can you
we
hear
have,
me?
yes,
Hello, Maureen.
please. Proceed, Buki. So it looks like we have lost Buki again. I think there's a problem with the strength of our internet. So what she was talking about.
I can hear you more.
So
Hello, Maureen.
Buki, we can't hear you clearly.
Sorry.
Hello? So looks like we've lost Buki, but in the interest of time, I just want to bring out some of the
Okay,
issues.
can you hear me now?
Okay, she's back. Buki, proceed, please. Is it me or? Okay, so what Buki was trying to present was around the importance of community-led service delivery for children living with HIV. And these community-led service delivery are supposed to address some of the challenges that children are facing with the challenges with pediatric and adolescent care in Nigeria. And some of them include delay in early infant diagnosis, and that is just what we have heard also from other regions. The loss to follow-up among HIV positive women, and we have heard that it's not necessarily sometimes the problem of the woman, but also the kind of care we receive at the facility. So the loss of follow-up and also bullying out of treatment. And then we also know that we are working in very challenging environment, and in light of COVID-19, there's poor access to pediatric HIV care services for children and adolescents in Nigeria and other parts of the world. Then we have known that most of our programs are transitioning to differentiated service delivery. And this has worked even in this COVID-19 season, because most people living with HIV are now collecting their ARVs in community settings, but we haven't had a good model for differentiated service delivery for pediatrics. And then also the issue of disclosure and access to sexual and reproductive services among adolescents is a big challenge. Most adolescents are not told their HIV status, especially those that were born with HIV. And therefore, they are not adherent to treatment because they don't even know what they are treating. So those are some of the challenges that the children in Nigeria are facing. So with those remarks, I think we can proceed. Yeah, and then, yeah, we can proceed to the next session. Thank you. So our next session, we are going to see how COVID-19 has impacted on pediatric and children HIV response. And then after that, we will have a panel that will join us to have discussions on the way forward. So please play the video.
Hi everyone, my name is Noktula Heath from the organization called Zoe Life. We are based in South Africa. The biggest challenge that children face living with HIV, due to COVID-19, some of the caregivers have not been able to go into the facility when children are not receiving proper education, and if children are not taking medication, this might pose a challenge. We have come up with some tools that will be able to assist caregivers to be able to explain to their children what is corona. For example, we have decided to name corona Rona Corona. For more resources and information around corona, please visit us at facebook.com/KidsAliveSA. Our call for action to our government right now is to continue support the frontline workers that are currently working in the facilities to provide services to the caregivers and the children that are coming to access treatment. And secondly, is to support the messaging that addresses Rona Corona to children and their caregivers and make sure that children are not left behind.
Hello, my name is Baby Rifona, and I'm a national coordinator for Women Living with HIV Network in Indonesia. In Indonesia, we're facing the problem of stock out of ARV treatment since early this year. We mobilize community at different level and pass to do the advocacy to the government, to the media, and also to the president, etc. In terms of the women and children who living with HIV, COVID-19 situation makes worse on their life about the availability of the treatment and also the economic. For example, there's a woman who get pregnant and have to deliver the baby, and then they cannot accessing the referral hospital, so the doctor refer them to the public hospital, and it's not covered by the insurance. So this become a problem for the woman living with HIV and also for the children. The stock out become worse now because we don't have any access for the treatment, especially for the children, and some of them, not only for the children, for more women and for the all people living with HIV in Indonesia, some of them even get the change regimen, not get the same regimen as usual, and then also some of them only get for 4 days only. We want the government to really pay attention about this situation, and also we need the government to take action seriously about our treatment, and also the HIV response make them at the priority, because in this COVID situation, from the national up to the district level, all the government, all the leader in the government taking action to respond to the COVID, but forget it about people living with HIV, especially women and children who not get access for the treatment, and difficult situation in this COVID-19 and lockdown, and the economic issues, and also need support for the household. And there is really need to pay serious attention from the government in every level. Thank you.
Hi, my name is Jacqueline Okinyi, and I work with Women Fighting AIDS in Kenya. Kenya is one of the countries that have been hit by COVID-19, and our government has put in place measures to ensure management of this pandemic. Our beneficiaries have also been affected in one way or the other. Some of them have lost jobs. Others have closed down their businesses. Poverty has crept in, especially the caretakers to our children living with HIV cannot now afford transport to take the children to the facility for the refills. They cannot also afford food to give to these children who are on ARV medication. As an organization, we would like to call on to our government to support the most in need households, those with children living with HIV, and those who are in child-headed households that have nowhere to turn to. Kenyan government, our children are taking ARVs without food. Others cannot pick ARVs from their facilities. Kindly support these children to enable them live healthy lives. Thank you.
Thank you very much, Saima, for the video. We have seen some of the issues that have been raised, including the challenges people are experiencing with access to services for children during COVID-19. We've heard of stockouts of treatment. We've heard of need for information to access services during the lockdown, and also issues around access to nutritional support for those on treatment and have lost their incomes. So that ends this first session and we are moving on to the next session to Florence Anam. Please continue putting your questions in the question and answer platform. Thank you.
Thank you very much to Maureen and the wonderful presenters in the first session. Your discussions have really laid a foundation for the discussion that this second session will take in. Could I have the panelists joining the second session to have their videos on so that we can be able to see you? The second session is basically looking at what do we do with what we have had currently. We have listened for the last 1 hour to facts, to the science, and to also community perspectives and the different work that all our stakeholders are doing and the challenges that they face. We have listened to what are the gaps and the challenges that people are facing, women particularly, and particularly within the context of COVID, in the attempt to ensure no vertical transmission of HIV and to ensure children who are living with HIV are able to access testing and treatment and to lead quality lives. If we look at the trends, we are quickly seeing that countries focused on addressing and meeting targets, the 1990 targets, and now the 1995 targets, will do so without having to focus on children. We know they can achieve those targets. So this session is about looking at us collectively. It's a wake-up call to all of us to figure out what to do differently and how to get everybody else involved to do this, not because we have to meet targets, however much that is important and necessary, but because we need to do it for our children. I am joined by wonderful speakers in this panel. We have Blessings Banda from PATA. We have Maureen Milanga from HealthGap, Sasha Volgina from GNP+, and Catherine Connor from UNICEF. I will just pose my questions to each speaker and they have about 5 minutes to respond. And please do not forget to put your questions on the chat box and they will be responded to by our very able team and also the panelists. Before we start, just a quick shout out to the ICW Young Media team. You're doing a great job. Thank you. We are glad to have you here. I will start with you, Blessings Banda. Looking at the opportunities that exist to hold activists, community, governments, and stakeholders, all of us collectively accountable, and looking at the response and in trying to map out a way between now, possibly to the end of the year, what country processes, in-country processes, do you think we can look at in terms of how we can influence change for our children?
Thank you so much. It has been an amazing discussion. But before we go any further, let us all remember that children do not always speak for themselves. So as we are looking at the country processes, we have to have that in mind, have that at the back of our mind, that children do not always speak for themselves. We need people, we need structures, we need advocates that will be speaking for children. So whenever I'm given this opportunity, I always say that it should be a collective manner. It should be the advocacy should not be for one person. I'll talk about the political will, and also how the big meetings at country level, are they really talking about children? Are we really prioritizing, are we putting a priority on children? Are we looking at the figures that we have, and also, you know, deciding what programs we should put up for children? So, you know, it all goes back to children do not always speak. We have to, or someone has to speak for them. Someone has to design programs for them to make sure that their service delivery is on point. That is something that everyone has to, you know, take away when we're finalizing this session. And also, we have a lot of programs that are that need to be advocated for. I'll give you an example: children that belong to sex workers that are on ART. What programs, what in-country programs do we have for them? So we have to design an advocacy program that will make sure that each and every meeting, the technical working groups that we have at country level, the meetings, that the Global Fund meetings, the PEPFAR meetings, these have to prioritize children. These must prioritize children. If we do that, I'm sure we're going to go a step further. And also, they represented. Who is talking about children? Who is talking about the community-based organizations that are down there? Is our approach a bottom-up approach? Are we starting our programs from the ground going up? Is it need-based? So if we look at who is representing and who is the voice for children at all these levels, it will also support us to make sure that from now up to the end of the year, or even in future, we have programs that are specifically looking at the need or the need in the delivery of the HIV programs for children. And then lastly, I'll talk about multi-sectoral approach. This response does not only belong to the health professionals. It does not belong to the Ministry of Health only. It does not belong to the psychosocial counselors at the clinic level or at the district level. No, we have to make sure that this is very sectoral approach. The Ministry of Education, the Ministries of Social Welfare, for instance, in Malawi, we have the Department of Social Welfare. They have to take part in this response, because if we leave everything out to the Ministry of Health, we're not going to achieve anything. We have a lot of work that is being done at country levels in different countries, Uganda, Kenya, Zambia, Malawi. But if we leave this to be a sole ministry responsibility, then we are not going to go everywhere. We will not go anywhere. So it has to be a multi-sectoral approach. All the sectors have to come together and work hard on this. I really love some of the approaches that are happening in my country, in Malawi here, whereby all the technical working groups that are managing child HIV programs, they encompass each and every sector that has to be that is responsible. For instance, even the nutrition sector, we cannot talk about HIV without talking about food. So it has to be everything has to come up in one pot. Everything has to be dished out from one pot and serve the children. So in a nutshell, I'll say that these three basic things that we have to work on, advocacy, multi-sector approach, and also the level of representation. These things, they will bring out the voice that we have to give to children that cannot always speak for themselves. Thank you so much.
Thank you so much, Blessings. And yes, on the reminder that children do not speak for themselves, and so it is our collective responsibilities to do that for them. And I also like how you have finished off with how everything needs to be on a pot, and from that pot, children need to also access their services and whatever else that is needed to ensure that there is reduced numbers of infections and access to treatment for the children. Which leads me to our next panelist. We know very well that within that pot is resources, money, that will drive in a large part how national programs, how to an extent the global market also gets shaped in terms of the treatment that is available, of the diagnostic equipment that is available to ensure that there are services for our children. Maureen, similar question, but what do you see as an opportunity to hold ourselves and to hold within the country or the national or the regional and global processes, like the Global Fund processes, right from replenishment to what is made available at country level, proposal writing, to the design of the programs, and also within the PEPFAR context. How do we hold these processes accountable for our children? How do we hold ourselves who are able to go into these processes accountable for our children?
Thanks so much for the opportunity. Just to begin with, for most of us on this call, we all know that PEPFAR, the Global Fund, are the largest funders of the treatment program across sub-Saharan Africa. I think most of us on this call as well are aware about the fact that within those resources, PEPFAR and the Global Fund are still the largest funders of pediatric HIV response as well. Despite all the successes that have been made within the HIV prevention and treatment program, these two programs have also not been greatly succeeding when it comes to provision of service delivery for children. And this has also been escalated, especially with COVID-19 now, where programs have really scaled back, and people who would ordinarily be able to access service delivery are not able to access service delivery, and we are really struggling to be able to give innovative ways of, we are struggling to have innovative ways of bringing services to people. Just for example, like if I was to speaking about PEPFAR itself, as a funder, PEPFAR spent $155 million on children in the year 2018, and they spent $167 million in 2019, which means that they are spending, if you look at PEPFAR spending, country operational plans are written every year. So every year they are spending more than 100 million on children. However, the same PEPFAR is refusing to, across multiple countries, expand point of care early infant diagnosis. Why? Mainly because they're saying that it costs too much, lab infrastructure is too cumbersome, they've built conventional lab systems and they don't want to change, even though they're not really truly supporting children. And this is where communities and our advocacy then steps in. If you look at the recent data, quarterly data that is presented by PEPFAR every 3 months, you get to see that they are not doing well. They are missing most of their targets with children. We need the people on this call, the people who care about children advocacy, to be able to be part of those processes. You need to be able to reach out to your country teams and say, we want to be involved in writing country operational plans. You should be able to access those, the option of being present if you ask to be part of the team. We also need to go ahead and ask to be able to join quarterly meetings, because in quarterly meetings, that's where PEPFAR then says, this is what we've done throughout the last 3 months in service provision. And that gives us an opportunity to be able to say, well, you've not done well when it comes to children. how do we change how we are doing service delivery with the 100+ million you have across your programs, and depending on how much money is in your country. The other way to be able to, when it comes to the Global Fund, representation of civil society in different spaces, in the spaces within the Global Fund is very important. Ensuring that young people, women, people who sit in the CCMs are able to speak about children, and being able to, and that they're also able to be very vocal whenever we have pushback within the CCM systems. Like Maureen was saying earlier on, countries are now currently drafting their applications, their main applications to the Global Fund. This is the time to go look at those documents and say, our document is missing point of care early infant diagnosis. Our document is missing better formulations in medicines for children going forward. How do we add those into the system? We also need to be able, when we talk about PEPFAR and the Global Fund, there's also an opportunity for advocates to be able to ask for resources to do something known as community-led monitoring, where us as community groups go out into the field and we visit the sites that provide services to children. And we're able to say, well, I went to site X in this district, and we know for sure that there is no point of care. We know for sure that there are no clinicians. We know for sure that there's no one supporting women who are coming to the facility. That is something that can be funded by both PEPFAR and can be funded by the Global Fund. Then with regards to national governments, the best way for us to be able to engage at national government level is to join technical working groups at ministry. That's where decisions are made. That is where policies are created. That's where people agree on whether they're going to do multi-month scripting or only provide 2 weeks worth of medication for women. So we need to be in those rooms. Making sure that we reach out to our ministries of health to be able to participate in those processes is very important. We also need to be able to make sure that our governments start to invest more in HIV. Right now, 90% of our programs are mainly funded by donors. Very little money actually comes from government, and mostly it's within the KCM under counterpart financing. So we need to be able to ensure that our countries are actually putting a bunch of resources for children. We need them to be able to write better circulars and better policies. We need them to, in these times of COVID-19, when Jackie was speaking, she talked about a lady who had been stopped at a barrier and could not access the facility. These are things that we can actually ask government to be able to give exemptions for women, for mothers, for people living with HIV to be able to access the facility at whatever time, because we know that there's a need for those sort of services to be provided. But for us to be able to do that, we need to be in those technical working groups that are actually asking for those changes to be made. Like ideally, I think in terms of going forward, like Maureen Murenga had actually said in the beginning, as partners listed in this slide, we went and we created the Kigali Declaration, and we had a lot of sign-ons, and we had a lot of acceptance from communities. But since then, we virtually we've really struggled to make sure that there's a lot of improvements in outcomes for children, despite all the pledges that have been made by Global Fund and PEPFAR and the UNAIDS that were made at the Kigali session. So we are asking the people on this call, one, because we need to push for better healthcare for children, we need you to sign on to the letter that we are sharing under number 1 that says that we need more access and better healthcare services for children. And we're also asking you that this should not be our first and final call. We need to be able to keep these discussions going forward so that we are able to strategize and work together and discuss even more in depth across multiple countries with multiple issues, So we're asking you to join us for another call on September the 3rd. And please email me. I will be happy to send you details on how to join so that we can work together going forward. Thank you.
Thank you very much, Maureen. And yes, hopefully we can have that, the link to the statement and the call and how to join shared with all our participants and beyond this meeting as well. So we can have, as you rightfully say, keep the momentum on this discussion going forward. Yeah. So my next panelist is Sasha Volgina from GNP Plus. Sasha, could you just a little bit for the many of us who may not know, describe what the Rome Pediatric HIV Plan of Action is? And also within your time, let us know what it is that we can be able to do within that platform to do our influencing for children. What can be done to push for children living with HIV within that space? And how can we do it? And who do we need to work with to be able to achieve this goal? Welcome.
Florence, great, thanks. Yeah, and this platform, Rome Action Plan, is very much related to what we're already talking about, because this is also one of the mechanisms which help us to make all that stakeholders accountable. Also, the thing is that it's not only like major donors. If you look at the slide, you will see who is involved there. It's not only major donors, it's also pharmaceutical companies. And I think that in our conversations, we lack this stakeholder today. We were not discussing that, but it's an important stakeholder, and it's important to advocate towards them as well. First, I came to this Rome meeting, I was pretty shocked because like everyone is all together, all the stakeholders, you can raise the questions. So I think we have to take that platform seriously. I think that we can raise the emergencies and some emergency issues there. We have to collect the information, what was already said, monitor, and then bring that to the table. So concrete emergency things can be brought there. I have tested that, it works. So the stakeholders do react. I remember quite great reactions from the side of the pharmaceutical companies, for example. The things which were not resolved on a regional level for a long time were surprisingly resolved. So we can use it for that. Also, it's one of the ways how we can get them accountable, I think, because this is one of the, like, everyone should report during these meetings on the progress which they're reaching towards their commitments. So as it was already said, there are quarterly meetings of PEPFAR, but also they have commitments in the Rome Action Plan. So we also can get prepared and can ask questions and can raise questions we have during that meetings. Also, I think it's a very good opportunity. And as I was listening now to the webinar, for example, with the early infant diagnosis, I think we can build the strategic suggestions, and we can build a strategy jointly with us, like several civil society organizations who are working under the roof of this Rome Action Plan. We can try to build joint strategy around that. Basically, as we're doing that in the other PCB board of UNAIDS or Global Fund board, like we have to get prepared, we have to discuss our strategy between the organizations, I think, and then come with some certain strategy and also understand who are our allies there. I think that we are in the beginning of the proper use of the Rome Action Plan. I think there is much more opportunities there which we can use. I think we have to, what people on the national level or regional level have to do, they have to reach out, and you see the list, the organization. They have to reach out to the organizations who are involved in that Rome Action Plan. bring them their concerns, also their organizations. I think we should work more closely, MSF, FR, you know, all of us, we should work more jointly. And develop our own strategies, and also work with the allies, because I think like working with the UNITAID, UNICEF more closely will also bring us more benefits, and our strategies, advocacy strategies, can become much more much more successful rather than they are now. Also, the last thing maybe I wanted to share with you is that what I felt when I first came to that meeting was I lacked the communities there, because we have faith-based organizations, we have, you know, huge NGOs there. From the community side, it's only GNP+. So I think it would be fair also to raise the question of the representation, because no youth organizations are there represented, no women's organizations are represented, because I think for us it would be easy and we would be more strong in our advocacy using that platform if it won't be, you know, just GNP+ from the side of the communities. It's too hard to represent everyone. Yeah, I think that's it. I think that it is promising opportunity. I think we're not using it 100% as it should be used. Just pushing for the priorities from Kigali information, doing it strategically and wisely will bring us the results. Thanks.
Thank you so much, Sasha. I think, though very brief, you have talked to us about an opportunity that many probably did not know existed. And as you rightfully say as well, we have to be represented if we need to move things. So, and sometimes just being one person in the room does not change much. So we need a little bit more of the community representation in these spaces, and to strategically and effectively use this platform to make a push for what we are asking for children. My last panelist is Catherine Corner from UNICEF. Catherine, there is a lot that is happening now, and a lot of opportunities have existed, and they are currently also in the process of going through some tweaks and changes, particularly probably at UNICEF level, but also the other UN partner agencies. What opportunities exist for us to be able to influence on issues for our children? I'm also looking at the current plans within UNAIDS to, update the global AIDS strategy. What opportunities exist there, and how can we tap on those opportunities to also ensure there is prioritization of children, as shared by many of our speakers in the past panel? Over to you. Welcome.
Thanks, Florence. And while I feel like I work at UNICEF, I actually work at Elizabeth Glaser Pediatric AIDS Foundation. But I'm really
sorry about that.
It's still got kids in the name. But no, I mean, having worked at Elizabeth Glaser for so many years, and her sort of being the original sort of mother advocate, I'm really heartened to see this call and this webinar today. And I think the speakers before me have laid out the really strong case on why this is so important. And I think we can all agree that if adult care was at the state of pediatrics, there'd be an uproar. And what I'm taking away from this conversation is just how upsetting, how unacceptable things are, and quite frankly, unconscionable. So it's good that I get to talk a little bit about some of the action steps happening with some of the UN entities. I don't think that oftentimes the national advocates look at those opportunities and see a role for themselves, because a lot of these frameworks or toolkits or meetings are always sort of listed as technical, that these are technical meetings with technical information. But frankly, all we've heard today is the information that advocates, community workers, people who really work in this area can bring to these conversations. And so while many of the frameworks you've seen, whether it's the last mile framework on ending mother-to-child transmission, ending vertical transmission, there's a pediatric service delivery framework that UNICEF has out. There's the Start Free, Stay Free, AIDS Free framework that's promoted by UNAIDS. All of them provide a lot of opportunity for national level action that just have to be sort of taken. And as Maureen was talking, and as Anna was talking, I was thinking, the Kigali Declaration is a great opportunity to say, what's in this Kigali Declaration that we could take forward using these frameworks? And, you know, when I talk to other people about these frameworks, I almost call them a treasure map for advocates, because everything is so stepwise. When we've talked about these issues, there's not a silver bullet. There's not one intervention that's going to solve everything. We need better service delivery. We need better technologies. We need more funding. And so we can't just go in with one ask. We have to think all the way through a pregnancy, through breastfeeding, through the early years of childhood, the school-age years. There's a lot happening. And if we don't, that's what these frameworks really allow advocates to do. And so there's sort of three things I want to encourage people to do as part of this, because I think they really line up nicely. You know, look at these frameworks as a bridge between that community level advocacy and that technical advocacy. Because when you look at these frameworks, they all have suggestions about differentiated service delivery, about health workforce. But if they're only made based on the conversations that are being given to them, they're not going to have that robustness. And again, Anna's story really stuck out to me, is how does a youth mother's perspective get brought to that conversation if a youth mother doesn't get to talk about it? How does a school-age child's situation get brought into those conversations? POC-EID, early infant diagnosis, is another one. I think the evidence from the community on how well it's worked, how the caregivers have adopted this technology, how much the mothers appreciate that technology will be that additional piece of information over the technical information that already exists. And I do think that that's that sort of bridging that these frameworks really allow. The second thing is it really allows for sort of meaningful engagement with technical partners in the Ministry of Health on sort of country level solutions. And I think most of the people on this call have worked in the field long enough that we all sort of recognize we get a lot of these global documents, we get a lot of these global handbooks, global toolkits, but if someone doesn't take them forward in country, they're useless. And so these tools give you a reason to start a conversation, give you an opportunity to say, hey, UNICEF put this toolkit out, let's have a conversation. And so it really allows you to sort of say, you know, how does this matter in our country? How does this matter in what we're doing? Because these toolkits do not push a one-size-fits-all approach to dealing with maternal and pediatric and adolescent service delivery issues. So it's a really great way to start that conversation. And lastly, I think it's really creates different entry points that sometimes advocates are used to. A lot of what we've heard today are about going to the big meeting. Let's get our stuff in the PEPFAR country operating plans. Let's get in the Global Fund proposal. But, you know, a lot of these tweaks, and I believe, you know, Maureen brought it up with the technical working groups, a lot of these dialogues are ongoing. The standard of care, new best practices are always emerging. And so we don't always have to wait for that big meeting if we have these type of frameworks that often include a consultation process with civil society, that include reviewing progress and making changes. And so it really gives advocates an opportunity to build a consistent, continuous dialogue that might not always happen when we're always focused on those sort of big global moments or those big sort of funding moments. And it also, and so one last thing is, you know, I think it also allows us to explore new partnerships. You know, that we tend to have sort of advocates on one side and the government on the other. And, you know, government's sometimes set for inaction. I think most of us who've worked in Africa knows that the policy making process can be slow. And so if that's what we're waiting for, but working with a UNICEF or a UN, they have a mandate to interact with government. So even going to them and saying, can you help us do this? As advocates, we need UNICEF to step in and talk to the government. We need UNAIDS to step in. It really provides different dynamics. So, you know, my call to action to the group here would be to review some of the frameworks, talk to partners in country, and see how you can mine that treasure map for things that can really take hold in your country. And then I would just add as a last thing, so you brought it up, is the UNAIDS is going through a strategy process right now. And a lot of that process has been sort of undermined or kind of derailed because of COVID-19. So advocates should certainly talk to your regional representatives, your in-country UNAIDS, to see how you can weigh in there, because there are genuine concerns that children may not get the due space in that strategy that they deserve. And so I would really encourage advocates to talk to your UN you know, peers and find a way to be active in that space.
Thank you so much, and apologies for going on and on about UNICEF. Catherine from EGBAF. And I think what you say marries with a little bit what Sasha just said and what Maureen said. We have, and Blessings as well, we have to have an interest as communities to get into these spaces. I remember 2011, 2012, when we were starting the global plan on EMTCT, the discussions we were having at community level was simple. The global targets were there, but we worked as a team to break that down to, hey, we want, your governments have signed on to this, and they said they will reduce new infections by below 50%, and they will keep mothers alive. And so there was that push, and there was excitement by everybody to keep, you know, stakeholders and governments accountable to meeting these targets. And so we need to probably debunk the myths that these meetings are too technical for some of us to attend, but also, you know, encourage interest and support people to be able to participate. So I see we have a time check for 10 minutes. I will just summarize by saying a little bit and then allow my co-moderator to summarize as well, that this discussion has been very exciting, and if you're not a little bit pumped right now and starting to think, what can I do on an individual level, then at your organizational level, then please join the call on the 3rd, because I think you will, you know, get a little bit more excited as well in that call. We need to work together. It's not, children won't speak for themselves. We have a duty to speak for children. There are so many opportunities that we haven't tapped into and spaces, and there is so much technical expertise on all of our organizations and teams that we can be able to pull together and draw from to get us to where we need to go. The issue of children within the HIV response is a critical issue. We need to give children a chance to live and thrive and achieve the best of their life and potential. In closing, I will allow Maureen to sort of give your final remarks and get us to the final of this call, the finishing of this call. Sorry. Thank you.
Thank you very much, Florence, and the team. And I think this has been quite a very interesting conversation, quite I mean, it jogs our mind and gives a zeal for us to continue in the advocacy for children. We have seen that we still have a lot of work to do. And I consider, and also we note the invitation by HealthGap to join them in the other call that they're making. So I think we have seen a lot of work that needs to happen at the funding level. We have seen the work we need to do to include communities in the response. We have seen the work we need to do to ensure that we are reaching the non-traditional processes, such as the traditional birth attendants and people who deliver at home, so that we leave no child behind. And we also have seen that we need to think through, how do we work during emergency? COVID-19 has just presented a very good scenario where we need to keep thinking through what happens if there's an emergency tomorrow. Will we lose children, or are our programs able to continue in service during emergencies? So I think this has been a very, very good learning platform. And one thing I know that it's not the end of this kind of dialogue. We still hope we'll have the almost 130 participants in the future dialogues around children. We hope that we'll even have more people engaging at country level, and actually to strengthen and use the existing opportunities to ensure that we have a placeholder for children. We know UNAIDS are developing a strategy, and right now they are doing consultancies. Let's also bring the issues of children there. We know the Global Fund is also has begun work on their next strategy. And as a delegation, we used to wonder, we need to invite global networks of communities, affected communities. And we were thinking we have a global network of MSM, sex workers, other key populations, global network of people living with HIV. And then we went to adolescents, oh, there's Y+, and then we went to children, and everyone was looking at each other. So I think this is a moment we need to think through. How do we bring the global advocacy for children all together so that we are able to bring the issues of the different regions and also strengthen our point of entry for engagement with the other, with the UN organizations and other global health organizations that are focusing on children. So thank you very much, and thanks. We thank the hosts for giving this opportunity and space for us to meet and have this really, really good discussion. So I send it back to Saima to close.
Thank you, everyone. We will be stopping the recording and ending the call. Bye.